All right. Well, welcome to the Clinical Consultation Network. My name is Bruce Davis. I'm your host for today. I had expected David Taylor to be my co-host today, but he has fallen ill on us today. So it is going to be Bill Feldhouse, our Assistant Director of Nursing for the Department of Intellectual Developmental Disabilities, who's going to serve as co-host today. So appreciate Bill being on. Bill, can you say hello to everybody?
Hello to everybody. Good to be here.
It's great to be coming to you today. My location is in my mother-in-law's kitchen. I'm on my way to the Governor's Task Force for Healthcare Modernization in Memphis, which is occurring tomorrow. And so I stopped off here in good old Camden, Tennessee, to broadcast this from my mother-in-law's kitchen. So that's where I am. Just a couple of quick notes I want to make. So we have, as I have noted for the last several weeks, that the TNAD conference is coming up on August 22nd. And we have a number of really great presentations. And I'm going to have to check with my engineer over here. Michelle, am I sharing the TNAD screen right now?
No. Just your title screen.
Okay, let's try this. And there we go. Now am I? All right. So again, I wanted to remind everybody about the TNAD conference coming up on August 22nd. If you want to be part of this system, part of this network, this is a really important conference to attend. And I'll tell you, the response has been overwhelming. There have been just so many people that are responding to and wanting to attend this conference that I don't think you want to miss it. It's going to be not only a great opportunity to learn some new things, but also a great opportunity to connect and network with other people in a way that you can't do any other way except going to a conference. It's one of the most important things. And you may have other national conferences you go to, but this can be your local conference where you can connect with other people who have like interests. And so, our primary interest is serving people who have co-occurring intellectual disability, developmental disability, and mental health disorders. So we encourage you to really come to this conference. Our keynote speaker this year is going to be Dr. Thane Dykstra. He's going to speak on how to win friends and influence people with challenging behaviors. I have to believe there are many of you out there who would really like to learn more about how to do that. And so Dr. Dykstra is a very experienced, very well-trained individual who provides services to people with intellectual disabilities, and he is going to be the keynote speaker at this year's conference. And beyond that, there are going to be several other presentations that are going to address all kinds of things that might help you get people to a point of being more independent, more capable, of carrying out the lives that they want to lead. So I encourage you to be a part of this year's conference. Okay, so we've got a very interesting case today. This is, we talked before about people who experience conditions that cause them to die or that cause death. And we have discussed a lot of circumstantial medical conditions that may be causing problems for them. What we haven't really discussed as much are end-of-life decisions, and I think this is such a key aspect of what everybody needs to understand. There's so many layers of things that are wrapped around this decision that I think it's very important that we explore this from time to time and understand more about how those decisions are made, the legal aspects of it, but also the more emotional aspects of it, the grieving process that goes along with that. So I have as a guest today Chi Ajafor. She is a registered nurse who is the nursing director for the Middle Tennessee region, and she is going to explain this case to us, and then we're going to get into a little bit of discussion about it. I also want to check before I move on, though, is someone from CompCare, Steve Hilgenberg or John Johnson? Okay. I'm not hearing that they attended today. I had invited them to be part of this because of their experience in making these types of decisions and their involvement in this particular case. But it was very late notice when we got to them, so they may not have been able to make it. So I'm going to start here and just let she kind of give us some explanation of this case, and then we'll go from there. But she, before I get into that, I just want to find out just a little bit more about people, and I think now, of course, I want to remind you, you're in complete control of what you might share here, but there is, if you could give us just a little bit of your background, tell us a little bit more about yourself and how you got into working with people within the developmental disability.
Well, like you said, I'm a registered nurse. I have been a nurse for about 39 years now. I started when I was 5 years old. So,
right.
So I have worked, actually my background is actually med-surg and, accidentally dabbled into psych. Before I came to Middleton Regional Office, I was at the VA in Murfreesboro. In their psych unit. And I have worked, here at the Department of Intellectual and Developmental Disabilities for about 18 years now, and have actually really fallen in love with the people we support and just love to advocate for them. So that's it in a nutshell.
Yeah, I was trying to think how far back, because you and I worked in the regional office together there for 7 years, and I was trying to remember how far back that was. And so apparently, even before you came to regional office, you were working within a short distance of me, because I was very near the VA hospital in Murfreesboro. So it's just kind of an interesting connection there. So, well, it's very good to have you today on here, and I can attest to what you're saying, that you have become an advocate for people with intellectual and developmental disabilities, and I think your position, your concerns in this particular case reflect that. So, without further ado, could you just tell us a little bit about this case and give us a little bit of a breakdown?
Well, I just want to start by introducing John. This is not the actual name, but he's a 51-year-old Caucasian male who loves to have fun, easy to get along with, and has good sense of humor, and loves to be at the center of attention. He smokes often and loves to celebrate holidays. He will have drinks or slush every evening. Watching wrestling and being pampered is one of the things he loves to do. And he also likes to eat out as often as possible. He loves hot dogs and bologna, and reported as having strong communication skills and not afraid to let you know when he likes or dislikes, but has started to use less and less verbalization. According to Companion, John started refusing meals in April. First, will eat 2 times daily, and then once a day, and later on progressed to once per week. He was also able to ambulate independently until April. No event was noted to have triggered these changes. Refusal of ambulation was in his home, and only ambulating when staff is holding on to him in the community was reported in most recent ISP, which was 6/19.
See, I was going to just share a little something real quick about this case, because this is when I first came to the regional office. He was one of the first people that was referred to me, and he was referred to me because he was working at a hotel, and he was doing work in this hotel as sort of, he would clean up the rooms, essentially. And so I went to observe him there while he was cleaning up his rooms, and I just wanted to underscore what you were talking about. Now, I never like to describe people with disabilities as attention-seeking, but he certainly he found that to be very important. He wanted to have people's attention. He liked to talk to people, it was almost like that urge was so great that it was very difficult for him to focus on tasks that he wanted to do. But that same characteristic made it difficult for him to work, but also made him just a delightful person to be around. He was just fun. And so, there was sort of that dualism. It was hard for him to get focused to work, but he was just a great, really fun guy to be around.
Mm-hmm.
So I just wanted to throw that in.
Mm-hmm. All right, sad to kind of look at where he is today, and from that time.
Right.
So these are some of his, diagnoses. He has moderate IDD, has GERD, gout, constipation, hypothyroidism, impulse control disorder, insomnia, seizures, mild open-angle glaucoma on both eyes, hyperlipidemia, diabetes mellitus, diet controlled, and lately dementia. Prior to his admission, which was July of this year, on the 9th of July, he was on levothyroxine, lansoprazole, polyethylene glycol, Lexapro, Fanapt, Colex, propranolol, Dalvaparex, artificial tears, multivitamin, Crestor, allopurinol, trazodone, megestrol, which was started at 621 to help with his appetite, boost, and loratadine. He was hospitalized from 719 through 726 and discharged home on hospice due to failure to thrive. The current concerns are significant weight loss of about 16 pounds since April, and refusal to eat starting April of 2019. Has some pressure injury, which resulted from malnutrition and weight loss. Initial diagnosis of this, pressure injury was 6/25/19. So I have, there are some labs here, and these are just the abnormal ones, with the exclusion of the hemoglobin A1C, because it's noted that he has diabetes, type 2 diabetes, but it was a diet control. So his hemoglobin A1C on 5/2 was 5.7, which is really good, and albumin was low at 3.4, calcium serum was 95. And his protein was 7.1, which was low. Glucose level was 120 at that point, and his thyroid hormone was 2.66, which was within normal. And B12 was in 1,105, which was high, and PSA was 1.3. He had a GI referral.
Let me stop you there with those assessments, Chief, and just for the folks who are not nursing folks, to maybe kind of just explain what these results meant to you as you were evaluating this case. In a nutshell, what are these telling you?
Well, the hemoglobin A1C, I just wanted to include that because that basically exclude, any issues with diabetes, and because it was a normal. Sometimes people will lose weight from uncontrolled diabetes, but that was not the case. And his albumin level was low, which is expected because of the weight loss and him not eating, and so. As well as the calcium, serum calcium, that's a misspelling there, and his protein level was also low. So the glucose level was high, was a little elevated, and his TSH was within normal range, and and his vitamin B12 was also high. I just added these just to underline the fact that, I mean, there are certain things that I kind of felt like needed to be ruled out. I mean, some of them are very obvious because, I mean, he was obviously malnourished, you know.
Right. And so some of these results you expected from the fact that he had lost so much weight, but were you able to rule out diabetes as an issue based on these results, or?
Right.
Okay. And you might have, what kind of reading might you have expected on the HbA1c to indicate that there was a problem with diabetic condition?
Oh, I mean, if his hemoglobin A1c was highly elevated, I mean, it will kind of suggest, you know, that he needed some treatment for his diabetes, but I mean, that was not the case.
Thank you for slowing down for me a little bit there. That was very helpful. Thank you.
You're welcome. And on 5/30 this year, he had a GI referral to further investigate weight loss, and that was by his PCP. And GI consult happened on 6/15. Actually, when I actually saw the report, it was actually 6/14, not 6/15. There was a recommendation for a colonoscopy during that consultation, and that actually was supposed to happen according to the consult, 7/8. But my understanding is that the agency was trying to walk through, which, you know, we actually had some email encounters, you know, trying to figure out what would be the best way to prep him for this test, knowing the fact that he's not, you know, eating is difficult. It will be difficult to get him to drink. I mean, if you've ever had colonoscopy, the prep that's required before this investigation. And so he never actually had this completed. Then on 6/17, he was seen by his psychiatrist, who actually recommended switching him from Fanapt to Zyprexa, because Zyprexa tends to increase, you know, appetite, to see if it will help with his appetite. But surprisingly, I mean, he made that recommendation, he or she, but when he wrote the script, he did not change it, you know, last recommend. So I'm not sure why that was the case.
I'm sorry, this is Eula. I am actually his companion. I am here listening.
Oh,
yes.
Great.
The site didn't actually write it as a order because we were having a circle of support meeting, and his nutritionist actually wanted to do the Maycase instead.
Wanted to do what instead? I'm sorry.
The nutritionist recommended the Maycase, and so they wanted to do that instead of changing out an actual psych med.
And so tell us about the purpose of the Maycase.
That's to increase his appetite.
Okay. All right, thank you for that, Beulah, and feel free to jump in at any point that you have clarifying information.
Okay.
Thanks, Beulah. So 6/17, let's see, okay. So on 5/2, actually, there was another recommendation for a colon screening, you know, from the PCP. So I don't know if, you know, actually it was a recommendation, but it was also at that point that, you know, the PCP recommended GI follow-up. So I guess it was addressed, you know, the colonoscopy was addressed during his GI follow-up. So, but on 7/19, he was admitted to Southern Hills with the admitting diagnosis as failure to thrive, acute renal failure, secondary to decreased PO intake. hypernatremia, secondary to hypovolemia, which is just, dehydration. And physical exam was completed during this admission, and it was actually unremarkable. CT scan of head without contrast showed no acute intracranial change, but also showed mild increased ventricular dilatation compared to that of 11/9/16. Impression.
Let me just say, that was very good that we had a baseline CT scan for him. That's not always the case. Why did he have, do you know why he had that original CT scan? Was it for this purpose, or was it was there some need that he had then to have that?
I am not sure, because I actually could not find that particular consult. I was able to, I saw this, in the report from Southern Hills. It was mentioned, but I don't know. Beulah, do you have an idea?
No, I wasn't with him at that time, so I don't know.
Okay.
So that's just one of those things we're not sure about right now. So we'll proceed.
Okay. So the impression from the CT scan was possible central atrophy, cannot exclude normal pressure hydrocephalus, given his decreased ability to ambulate, increased urinary incontinence, and change in mental status. And then it says a neuroconsult referral. So again, I did not see a report on this neuroconsult, so I don't know. It may have been completed while he was in the hospital, but I wasn't able to find information on that, on the neuroconsult. And Beulah, I will, have you join in if you have any information on that. Do you know if it was ever completed?
You're talking about the CT scan?
No, the neurology consult.
No, we weren't able to actually go to the neurologist because of the most recent admission into Vanderbilt and then him coming out on hospice.
Okay. So, and then he did mention that clinical correlation, is recommended. That was from the CT scan report.
So the idea is you would not just go with the CT scan and say, okay, end of discussion. You'd want to have the neurologist examine him and be able to provide additional information about whether or not this might be dementia or might be something else that's going on with him. Is that my understanding correct?
Correct.
There's too much stuff that you cannot see on a CT scan. And so I would agree that would not be sufficient. My question is that what was the very first symptom? Was it when he quit eating, or was there symptomology already present before that occurred?
No, it was the fact that he wasn't eating, and because he wasn't eating, that led to him being more weak, not able to hold his own feet. And so that, for me, that was an indication of, okay, something's going on. And so I kind of just watched his eating, monitored his eating for, about 2 weeks. And when I noticed that he wasn't, he would go all day with maybe eating one meal or a whole weekend and not eat anything, then that's when I went ahead and brought it to the, to everybody that was dealing with this case.
The hard thing about that is that, once they quit eating, it becomes very difficult for them to start again, because once you quit eating, it sets up a cycle that begins to occur. And if they are already compromised in more than one area, it's very, very difficult to get them started again. Something that was not mentioned was, did anybody check his teeth? Could it have been tooth pain that was keeping you from eating initially?
He had a dentist appointment. I don't have the date, but every dentist appointment that he had, there was no issues with his teeth at all.
Okay. Did he have underlying nausea? Like when he quit eating before, was he able to express how he felt as a reason for why he wasn't eating? Is it underlying nausea?
That he wouldn't be able to say, verbalize if he was nauseated, but there was no signs that he was nauseated, because he would ask to eat. And, you know, one of his favorite things, the last couple of months has been cheeseburgers. So we would give him, you know, go to McDonald's, get him a cheeseburger, and he would maybe take a bite and then not want anything else. He would refuse to eat it, or he would just eat the meat and take the bread and everything else off of it. So it's just little things like that. So it wasn't that he completely stopped. I just noticed that the amount he was eating drastically changed before it got to the point to where he actually stopped eating altogether.
Well, I think that's important to point out. How long had you been with him, Beulah?
It would be 2 years this December.
Okay, so you were able to kind of detect this smaller change in his eating habits.
Exactly.
Which gave you an idea that he was moving in a direction of not eating as much, and so that's
correct.
That's a really important thing, I think.
Because I do, you know, I cook their meals. He does have a roommate who is diabetic. So when I cook, you know, I make sure that I cook healthy meals. And so I was able to monitor, you know, what he was eating, how much of it he was eating, and things like that. So I know that was the first thing that I noticed.
And he was being offered things that previously he had eaten well, but now.
Oh yes, and you know and for his lunch is really when he would go out to eat is for his lunch, and so you know we would always get him whatever he wanted, which either cheeseburgers or pizza, and so after you know we would go and buy what he wanted, then that's when you know he started out with eating a whole cheeseburger, a small fry, and then it started to where he would only eat the cheeseburger, and then he would only eat half the cheeseburger, and then he would only eat a couple of bites of the cheeseburger. So it was a gradual thing, but it all happened so quickly within, you know, a month's time of all of that happening.
Okay, so it was compressed to a month's time. It wasn't like.
Correct, because when I first noticed the eating change was in April, and by the end of April, he had gotten to the point to where he would go a whole weekend and not eat anything.
All right, well, that's meaningful.
So there was a question about dental. His last dental appointment for cleaning was on 5/8/19. And there were some dental caries dictated, but other than that, there wasn't really much findings.
He had a few cavities, no severe problems with his teeth. He wasn't complaining of his teeth.
Right. Okay. So, there was also a mild microvascular ischemic changes in white, matter based on the CT scan. And there were some, abnormal labs during that admission to Southern Hills, which were all related to his nutritional status.
Uh-huh.
So he also had an EEG with, and the conclusion was an abnormal wake EEG with moderately severe generalized slowing, consistent with encephalopathy and or diffuse degenerative process. No electrographic seizure or epileptiform discharges.
I'm trying to go back. I'm trying to remember back from the original information. He did have a seizure disorder, correct?
Pseudo seizures, that's right.
Pseudo seizures. So he had never been diagnosed with a legitimate seizure disorder.
Not that I know of. It was just pseudo seizure.
Okay. And there was no abnormal EEG under the circumstances. There was some generalized slowing, but nothing consistent with the seizure disorder.
That's right. And his chest X-ray during that admission was negative. And he was discharged with a diagnosis of dehydration, steam breakdown, and possible UTI. Possible UTI, his urine white blood cell count was very high during that admission. So as if that's, where the diagnosis of UTI came from. So, and the treatment that was provided during this time, his nutritionist Mary Eva Gregory recommended Negate, which was to boost, his appetite and to promote wound healing, because at that point he had some pressure injuries. And on 6/25, he was diagnosed with stage 3 pressure ulcer. And the wound care physician recommended increasing his protein intake. As stated before, his admission to Southern Hills was on 7/9, and he received some IV therapy. And while he was admitted, then a neuroconsult recommendation.
Let me back up on something you said a minute ago, because you mentioned him having a UTI, and I think some people might recall some discussion we've had in previous clinical consultation networks, where sometimes people who are experiencing UTI may experience mental health concerns associated with that. The difference in this case, it seems like to me, is that the cause of the UTI was the lack of fluid intake, right? So it was more the effect than the cause of what's going on with him right now. Would that be accurate to say?
Right. Dehydration will heavily contribute to UTI. Yes.
And because he wasn't having much intake, he was experiencing the UTI, which could have compounded his mental status, or the concerns over his mental health, but was not the primary cause of what was going on with him from a mental health or medical perspective.
Very, very likely, right.
Okay.
So, and then he was discharged from Southern Hills. It was 7/13, and when he went back home, nothing really changed as far as his ability to eat. So on 7/19/19, he was readmitted to Vanderbilt due to inability to empty his bowels as a result of being very weak. And nasogastric feeding was put in place to assess tolerance while he was at Vanderbilt. And from what I was, told, he tolerated that feeding because he was able to regain some of his strength, while he was receiving feeding through nasogastric tube, which is a tube that's inserted through, the nose down to the stomach. So his swallow study revealed aspiration of fluid, according to staff. I haven't really seen this report myself. So the enteral feeding was actually started on 7/23, and that was after a swallow study with no report of intolerance of the feeding. He was reported to have had a chest X-ray, abdominal and pelvic X-rays, which all, came within normal range. And He has continued. He was discharged home on the 26th, and he has continued to have a reduction in intake, and mainly would take some thin liquids, and so as Dr. Davis mentioned earlier, he was discharged home actually on the 26th under hospice care. Prior to that, the nasogastric tube was removed. So he is currently taking whatever he can take by mouth and able to get his medication. He's actually only on levothyroxine for his thyroid and valproic acid and PRN Coles and PRN Tylenol. So he is mostly receiving comfort care at this point. And I will actually like for Beulah to kind of share what's going on at this point. She's
I can do that. Since he's been home, basically, like she said, it's just, comfort care. He's still refusing to eat. He will drink, and we do have Ensure Clear, which is more like a juice, and he drinks that, and he's drinking water, but he is still refusing to eat. So he's just, in bed, sleeping off and on all day. He does still ask to go sit on the porch, so we will put him in his wheelchair and sit him up and sit him on the porch. After usually about 5 minutes, he starts to lose his energy and he starts to hang over the chair, so we'll bring him back inside and put him back in the bed. But at this point, that's all he's doing is, wanting to go outside and sit in the fresh air and just drinking.
Yeah. I know from previous conversation with she that she had some concerns about withdrawing the feedings for him. But I'm mostly kind of interested in your response to all of this, especially since you've been with him for a couple of years. How is this affecting you?
It's hard. I'm taking it one day at a time. I try not to think ahead of what's coming. I get up every morning and, I go and talk to him and see if he needs anything, and I go in off and on all day and talk to him. Whatever he needs, he gets, but I just try not to think about what's coming. I take it one day at a time.
Is it difficult for you to not want to do more for him?
It is. We do have day staff that comes to take care of him during the day, but where I can actually be off and kind of, get a little rest. But that I can't say at this time that that's really working for me because I'm still there. I can't help but be hands-on, especially now. It's very difficult for me to be away and not actually, do things for him.
I think this is perhaps one of the most difficult things, especially and perhaps underestimated concerns with a situation like this, is how difficult it is for the direct support professionals who develop a relationship with this personality under any circumstance. It's difficult to implement hospice. And this is an equivalent situation where you have a relationship with him.
Exactly.
And you've been with him over the course of 2 years.
Exactly. And and I still have to take care of my other client. His roommate, is there, so I still have to give him attention as well. But it is difficult. It's difficult, especially having different ones come in. Hospice comes in and they're talking about, you know, the comfort box and just different things to make them comfortable, and seeing all of that equipment in there is, you know, coming in, Wayne, you know, he still needed assistance, but, you know, he could stand, and he could walk with assistance. We would go to the zoo. Last summer, we were at the zoo almost every day. He loved going to the zoo, and just the drastic change from one summer to the next is very difficult.
So was John involved in this decision to accept hospice?
He wasn't involved as far as making, you know, I mean, that decision was taken for him.
Okay, yeah, because he has a conservative who makes healthcare decisions.
Exactly.
And so that's, you know, legally that is the decision maker in this circumstance.
Correct. And even with that, it's kind of hard for me. I mean, I do know, you know, this whole time that he had a conservator, but I still, even at this time, I was, you know, I didn't have a say, and I kind of felt like, you know, this is my guy, I'm taking care of him, I should have a say, but I got to also realize that I don't have a say. So it's just difficult to have to go along with what's going on, you know?
Right. Okay. And I know you had some concerns about this.
Yes, I did, because, you know, I was looking at, you know, based on the information I put before you, you know, this afternoon, I didn't see, you know, he never had a colonoscopy, he never had an upper GI, he didn't even have a neurologist consult to know exactly what's going on, you know, and I felt like, you know, maybe if he had gone through extensive investigations, maybe through that, I know that everybody is kind of focusing on dementia, but the sudden onset of all this kind of still, you know, it's so very unsettling for me. I kind of feel like, okay, you know, these things are supposed to be done before you know, give somebody a diagnosis of failure to thrive. At least see, you know, if you can find out what's going on. So even, I mean, with Southern Hills, with, you know, Vanderbilt too, I haven't really, I may not have all the information, but the one I have did not, to the fact that, you know, they even tried to they actually did mention that he had a colonoscopy, that nothing was found, but that was not correct because he never had a colonoscopy completed. But Vanderbilt have in their report that he had one. But that
he didn't have a colonoscopy. They did a CT scan of the abdomen, but they didn't do a colonoscopy.
Was the conservator aware of your concerns, Chi, or have you had any discussion with the conservator?
No, I haven't had any discussions with him.
Yeah. And do you want to say you didn't reflect or weren't able to reflect any of your concerns to a conservator or anything?
No, because anything that, you know, any decisions that were made while he was admitted into the hospitals back and forth at Southern Hills and Vanderbilt, the hospital social worker called and talked to him directly, and they made those decisions and they talked about that.
I see. Okay. Well, and I don't want to I wish the conservator were here to give us some more information about how the decision was arrived at. And we understand that this is a legal matter in some sense, but it's also an emotional matter. And I think one of the things, Beulah, that you're pointing out here is the tremendous effect that this has on others. And I understand your feelings in this situation because I recently had a situation my father-in-law went through hospice. I can tell you that even under the circumstance where we're all committed to that, he had made his own decision to have that. It was a difficult time. It was 9 months that we experienced that. And there were times where we all questioned what we were doing and if it were the right thing. And so I just want to kind of tell you that I understand completely how you felt in that situation and understand also how difficult this can be. And I don't rule out the idea that staff may need some emotional support as you go through a situation like this. And the other thing I wanted to bring out, though, about decision making is, so we talk about capacity to consent sometimes, and so when a person has a conservator, it's been determined basically that they don't have the capacity to consent to medical procedures. And so that's why a conservator is assigned to make those decisions. But any decision that is made, whether it's by a person supported, whether it's by a conservator, should be a valid consent. Now, what are the things that cause a consent to be valid? One is that the person that is providing the consent is rational. So in other words, they're basically able to weigh options and think about the pros and cons, essentially, of one decision over another. And so in the case of the conservator, we certainly say they are rational. They were put into that position because it's a rational person. Another component of the decision is that it must not be coerced, and there must not be any deception associated with the decision that's being made. So that's one of the things a conservator is there to protect against, is that someone's not being forced, essentially, or easily deceived into making a particular decision. And then the third leg of this is that the person must be fully informed. And so that's the piece that usually can come into question a little bit in these types of situations. And so that's the reason a moment ago, Chief, I was asking whether the conservator had been made aware of the concerns that you had about the decision that was being made, because maybe there are certain elements of that information that person did not know. And so as a result of that, it's really important to make sure that somebody has all the information. And the truth of it is, there are very few decisions that are ever made where a person has all of the information. They're trying to make the best based on the information that they have. And so where there's additional information, that needs to be provided. And that perspective needs to be taken into account as the decision is made. So I highly encourage in this circumstance communicating your concerns with the conservator. He basically continues to make this decision on a daily basis going forward. The other piece of this that I wanted to bring into the conversation is I do think it's a very important thing to take into account the person's perspective. And so to some extent, what the conservator now is not required by law in Tennessee to do, but what we generally think is an important piece of this is using substituted judgment. So in other words, they try to put themselves in the position of the person and try to make a decision from their perspective, essentially, as to how they will proceed. And would the person in this circumstance make the decision to go into hospice? Would they make the decision to go get further treatment and try to sustain life at that point? And so that's a tricky thing, though, when you try to substitute your judgment or substitute for someone else's judgment, because it's really hard to know what's in the mind of another person. One of the big deficits we have for people with intellectual and developmental disabilities is that there's not enough discussion of this earlier on, where there is some ability maybe for the person to participate in the decision more actively, and where we can get a better idea or understanding of what their decisions might be under a difficult situation. So we're all familiar, I'm sure, with living wills that are done to help guide the decisions, the later decisions, or actually make in advance those later decisions regarding end-of-life care. This issue, I think in every circumstance where you go into hospice, there are these questions that emerge with respect to this. And I've many times when my father-in-law and actually my mother also went through the same condition, that that there are always questions on both sides of this. Is this the right? Yes, this seems like the right thing to do, and yet on the other hand, it seems counterintuitive to everything we do as humans to back off and to say let the natural process occur. I was actually doing some reading of some articles related to this. There was one, and the AAIDD has taken a position on this that they're concerned about it because there is somewhat of a tendency to maybe make this decision more quickly when the person has a disability. But they say withdrawing or withholding care may be appropriate in some situations, but treatment should not be withdrawn or withheld only because the person has a disability. Now, I think the people who are involved in this situation are all very well experienced with people with disabilities, and so I don't think anybody would be making this decision based on the person's disability. But that's one of the things as we're making decisions of this type that we want to guard against and that we want to be concerned about moving forward. And it probably means that there should be some discussion back and forth about whether this was the best decision or not. On the other hand, there are also, there was a huge situation that was occurring in some states where people that was concerned about people having limited access to end-of-life hospice care. And so it was very difficult if the person couldn't consent themselves for people to make the move to actually have them have a hospice care. Because people are saying, well, we don't have the capacity to consent to it, so we're going to continue to do life-sustaining care. So you see how it comes from both sides. People not having access to that when they want it or need it, but also maybe decisions that are being made to force them into that or press them into that when that might not be something that they would want. And so I just would say that these are very difficult things. I would encourage both of you in this circumstance to share your concerns with the conservator, to make sure that those things are known and that becomes part of that decision-making process. And so, I don't want to make it seem as if, well, any decision that's made is a permanent decision. There can always be other information that's considered, but at the end of the day, we do have to respect the person who is legally appointed to make that decision. So, it's an information provision scenario, I think, versus one where we can, enforce our will in those circumstances. So, and the other thing I just want to really underscore again is the need for support, for direct support professionals, for others who are involved in the care of a person who may be declining in health and who may be having these sorts of difficulties. Chi, I want to thank you. Beulah, thank you so much for your input on this discussion. I think it's been very enlightening for everyone who has participated. And I am so thankful to both of you for participating in this today. And thank you all for joining us on the Clinical Consultation Network. This is done every Tuesday at 1:30. If you can't be with us in person, then you can hear the recordings on the DIDD website. So if you go to the DIDD website and just access the Clinical Consultation Network page there, you can get to all of these recordings. And so I encourage you to do that if you're not able to make it. But always try to be with us every Tuesday at 1.